I will start by being afraid that I can keep my mouth shut and be presumed a fool, or I can open my mouth and confirm that. But Doug, I wonder if what is known about ovarian cancer patients that have homologous repair deficiency or BRCA-like tumors and the interface with family history. Is it known, or is it just not known? Is there any crosstalk between cancer risk and treatment response and family history, going from the micro to the macro?
So is the question whether patients with a somatic mutation in BRCA would have an inherited predisposition to ovarian cancer?
I'm wondering more if, I don't know, if there's something more unmeasurable about HRD that is in something heritable that we're not measuring yet.
Well, I guess I would just say that we're always looking for modifiers of penetrance. And so while we know that 20 to 50% of the carriers will get cancer, of course the other ones won't. And there's been large studies, there's some low penetrance, predisposition alleles. Karen probably knows more about this. There's work from the SIMBA consortium. So obviously all DNA repair deficiencies are not created equal. Maybe there's a second defect locally or systemically that's required to actually start the tumor.
And it sounds like David's going to collect that information, because I saw that you were collecting. Were you collecting family history information for the impact study?
Yeah, we actually, I didn't even really get to it, but we obviously are sequencing tumor normal pairs. So there's two kind of efforts. I think that's being discussed by Mark or Ken today. So that's why I left it out of the talk, but there is actually an effort to go through and annotate the germline in patients, and there's a consent in place to do that. And we actually have an electronic family health questionnaire that patients are going to be offered to complete. And then the ones that have interesting family histories we don't find, there'll be opportunities for discovery, and that's something that Ken's leading.
Great, thanks. Dr. Akajanian.
So two questions. First, for Karen. One of the things that we sort of grapple with or don't know what to do about relates to this group of CAH or grade 1 cancer patients who are wanting to preserve their uteruses, preserve fertility, who have Lynch syndrome. Mm-hmm. We've been testing these DNC specimens, mismatch repair, IHC, and identifying that this young patient population, that we're seeing a fair rate of Lynch syndrome in this group, which is something we really hadn't incorporated into our thought process before. That IHC testing a lot of times was only done on the hysterectomy specimen, and something we kind of didn't know about when we were making this decision. How does that play into our counseling of a patient, whether it's safe or not to delay hysterectomy?
It's a great question. I think the only, so there's not a lot of data on that. The only data is that when we did our chemoprevention study in Lynch syndrome and really looked at the endometrium, it responded in the same way. So that was reassuring. So, kind of if Lynch syndrome endometrium responds positively to progestins, then, kind of one could kind of say that they would, that it's not out of the question to consider conservative management in those women. That I actually have not had that come up, so that's an interesting.
It's actually been coming up with us more, that we've done more automatic reflex IHC, and since the DNC specimen is what we have, we've identified this, so it's now sort of entered our counseling that this is more universally done, and we had to take a step back and go, well, does this change anything? It certainly changes some global counseling, but yeah, sure. And the second question has to do with a little bit of the morning session, but then went over to what Doug was talking about at the beginning about the different types of ovarian cancer, and they're not all the same, and that we really are diagnosing in our Lynch syndrome patients, when we diagnose quote unquote ovarian cancer, these are our clear cell or endometrioid grade 1, 2 patients. These are not high-grade serous patients. I've never seen one. And I think when we get those presentations that come out that say, oh, the risk of ovary cancer and Lynch syndrome is 8% or 4%, whatever it is, it's misleading, I think, to people to like categorize that the same as a BRCA mutation. The whole field of RRSO for fallopian tube origin and prophylaxis and risk-reducing surgery that's been developed for the BRCA patients, we sort of add the BSO, the hysterectomy and endometrial cancer, and I'm just wondering if it makes sense. And I don't know if the community really gets that difference. I mean, I saw a patient the other day, a young woman who has a clear cell ovarian cancer or locally advanced cervical clear cell cancer, and you know, she had had a panel test sent by her private practice doctor that showed an MSH2 mutation. She's the sentinel case in her family. You know, would a RRSO have prevented this? I don't even know. Or would a hysterectomy alone prevent it because it removes the endometrial? I just don't think people really understand that.
Yeah, I mean, the problem with it being not one disease is that a lot of the studies, for even the consortium risk studies, where they look at risk alleles,
They don't
those
say
studies
what
used
kind.
to not have histologic subtypes. Now they have some subtypes, but I can tell you for the serous cases, it's a serous ovarian cancer. You don't know if it's high grade or low grade.
Right.
For all the screening studies, we know that the transvaginal ultrasonography is quite good at picking up non-serous stage 1, you know, tumors.
Right.
And so in relation to you know, the screening for Lynch syndrome, well, do we know, is a clear cell Lynch cancer also very likely to be stage 1 and curable, or are the clear cell and endometrioid Lynch cancers more aggressive? And Karen's done a lot of work in the area, but I think, you know, a lot of these questions we don't know. So for now, you have to, you know the subtype, but whether that can affect, you know, stratifying the recommendations, probably hard to do.
And then throw in the moderate penetrant genes. So I think
Right.
that's, you know, I mean, so that's Lynch
Right.
syndrome where we have at least data, you know, then throw in, I'm seeing PALB2, BRIP1, you know, RAD51, and, you know, we barely know risk, let alone issues of histology. And then just one other comment related to that as well, which is so interesting, is, you know, I think the whole BRCA story is interesting because, you know, it's so consistent. The histology, the genotype phenotype is so tightly linked, you know, kind of BRCA mutation, high grade, either serous or endometrioid. But with Lynch, it's really kind of histology all over the place. And so, you know, there's a difference between genotype and phenotype.
But is the histology all over the place, or is our ability to diagnose a consistent histology all over the place?
Well,
So-
there's pathologists in the audience, so.
Right. So, and I can't help but jump in about the screening comment that, oh, we're very good, you know, screening could pick up those stage 1 clear cells. Maybe.
That's what they're picking up. The ones they're picking up are often.
And
you know.
maybe the reason the screening can pick them up is because of their biologic predisposition to remain stage 1 long enough to be detected. One of my pet peeves about screening. Yes, Dr. Soslow.
Wanted to jump in here, and I agree that the spectrum of malignancies seen in BRCA is very narrow. But I believe that the spectrum of malignancies you see in Lynch syndrome is also very narrow. So just to reiterate our own experience here, essentially all BRCA1 germline mutant patients who develop carcinomas develop high-grade serous carcinomas. There are 2 separate types of high-grade serous carcinomas. One is the type that any practicing pathologist can recognize, and the other is a tumor type that had been previously designated high-grade endometrioid carcinoma. We just finished a number of studies indicating conclusively that those tumors are not endometrioid from a genomic perspective, nor do they behave in any way like non-syndromic endometrioid adenocarcinomas. So that's my comment regarding the BRCA syndrome patients. And regarding Lynch syndrome patients get endometrioid carcinomas and they get clear cell carcinomas, period. The rare cases of mucinous carcinomas that have been reported and the rare cases of serous carcinomas that have been reported are microsatellite unstable endometrioid carcinomas, which are now known to have quite a bit of intratumoral heterogeneity, which when underappreciated could be misdiagnosed as either a mucinous or a high-grade serous carcinoma. So
Thank
thanks
you.
for letting me step in.
Yeah, for sure. Dr. Kaus.
Hi. First of all, great talks from all three of you. And also, I'm going to follow up with like Carol and do two questions. The first was actually directed towards Doug. And I'm just kind of curious about the genomic scarring picture. And obviously, we're seeing a similar genomic scarring picture in both patients with germline or somatic BRCA mutations and patients with methylation of the BRCA1 promoter. But from the TCGA data, as well as data from Alana Cass, the methylated have at least a clinical picture that much more resembles wild type high-grade serous ovarian cancers, as opposed to the improved prognosis that is clearly seen in BRCA2 and possibly seen in BRCA1. And so one thing which I just want your comments on is how well we can use the genomic scarring that's associated with homologous recombination to direct targeted therapy, or is it still, I think, or is it perhaps premature at this particular point to just use that genomic scarring to identify candidates for PARP inhibitors or other targeted therapies?
Right, so obviously it's in a research setting because PARP inhibitor is not approved for the indication of genomic scarring. So once maybe some confirmatory studies like Ariel 2 and others are done, if there's a consistent pattern that patients with genomic scarring have an improved outcome, maybe after 27 prior cycles, a PARP inhibitor will be approved for patients who have a positive genomic scarring score.
Okay. The second question actually could go for both either yourself or Dr. Hyman. Is one of the things which clearly I think the biggest issue in terms of mortality in the gynecologic cancers still relate to either serous ovarian cancer or serous uterine cancer, which both have the highest mortality respectively for the disease. However, both are associated with high levels of copy number alterations, but not actually many identifiable sequencing mutations within specific genes. And so just I'm kind of curious about what are the current thoughts of ways to target these patients with high copy number alterations, which don't necessarily happen to have repetitive identifiable driver mutations.
That seems like an easy question. I think that's the big challenge, and that's been the big disappointment for me as a kind of person who works mainly in targeted therapy, but my clinical focus is in gynecologic cancer. I mean, some of the copy number alterations themselves may be targetable, such as ERBB2 amplification. We've already seen responses in basket studies targeting those patients, but I think it is an issue. And actually, I actually don't send my serous ovarian cancer patients for impact testing because I just almost never have found anything that I can action on with current therapeutics. So I don't have an easy answer to that. Obviously, you know, PARP inhibitors are one path, but they're not going to be the total picture. We need more, and I don't have a great answer to that question, actually. And the last thing I'll just say about the first question is the genome scar, at least my interpretation of the data so far, and it's obviously pretty immature, is that it seems like the negative predictive value is good on those assays, but the positive predictive value is fairly low. So it may help screen out patients who are unlikely to benefit, but when you look at the response rate and the outcomes, they don't seem quite as good as the germline patients. And one of the things we're going to look at here is how these genome scar assays, which are not that difficult to reproduce, it's just a matter of where you set the cutoff, compared to things like true loss of heterozygosity in the tumor and normal pair, which we can detect when we do sequencing in the tumor and normal. So hopefully we'll be able to see how loss of heterozygosity of BRCA2 does compared to these genome scar assays, for example, even when it's a somatic event.
I thought Doug's slide with the variability was really, compelling. It makes you think about the ones you'll miss from the wild types, and I don't know, it's very interesting. And Paul, did you have a question?
Yeah, and this is just a very basic clinical question, but based on the data you guys have with grade 1 endometrial cancer, adding aromatase inhibitors to everolimus, for example, and if you look at the data emerging in breast cancer,
Yes.
combining hormone therapy,
Yeah.
if you treat a patient with everolimus with endometrial cancer kind of on its
because we did the single agent everolimus, and there wasn't a significant.
You would add it to everyone.
Yeah.
So-
Can I ask a question? The trial, the basket trial with the AKT, is that the specific AKT mutation that you were talking about, or is it all AKT mutations?
Yes, that's a great question. The study was vague in terms of the molecular inclusion criteria. We decided to initially only enroll the E17Ks, which actually is not that difficult to do because they're the predominant mutation. But whenever you do these broad sequencing panels, you find passenger mutations that probably are these non-canonical, non-functional mutations. But as we started to get more experience and felt we were reaching some bar with the E17Ks, we started to expand to select less common hotspots like the Q79, the L52. So we do have a couple of non-E17Ks in the study, but they're predominantly E17Ks. And I think that's a challenge when you do these studies, is it really has to do with what your tolerance for failure is, how broadly you set your molecular inclusion criteria. If you select the mutation that you think is most likely to respond to the drug, it limits your population, but it potentially raises the response rate. And actually, even outside of the AKT1 isoform, we see AKT3 E17K mutations. We see Q78 mutations in AKT2, which is the pyrologous residue to the Q79 and AKT1. So that was a little bit of what I was showing on that figure. And so we've actually worked with our bioinformaticians to identify other mutations in the gene or in other isoforms of the gene that we think are likely to perform or have similar biologic consequences. But every study is a little bit different.